We are going live in 5, 4, 3, 2, 1. We are live now.
Thank you. So, very good morning, all the dear fellows. And we have a very important session today, and that is Relapse in Clubfoot. I always tell my fellows that if you wish to develop your pediatric orthopedic practice, first you learn how to treat clubfoot and the relapses. I remember in the second month of my practice, when I treated one clubfoot child, the family came with a patient with scoliosis, and he said that sir ne ye to पैर 90 डिग्री बेंड था, करेक्ट कर लिया, ये तो 50 डिग्री है तो वो कर लेंगे. So clubfoot makes the basis of your practice, and we have one of my very dear friend, Dr. Atul Bhaskar, and he has a lovely paper on relapsed clubfoot. So Atul will take us through his approach of treating relapses, and I would ask Chinmay and Shalin to start the session.
Yeah, sure, sir. Good morning, everyone. So today's in Orthokids fellow schedule, we have a lecture on relapsed clubfoot, which was taken up by Dr. Atul Bhaskar. So Dr. Atul Bhaskar, after completing his education in MS Ortho, he completed his pediatric orthopedic training from UK and as well as from Hospital for Sick Children. Sir have a different publication over clubfoot, DDH, and Monteja fractures, but especially a pioneering work in conservative treatment of clubfoot as well as its relapse following the positive techniques. Such paper, which was published in 2013 over relapsed clubfoot, give us a classification which divided into a 4-part, which give us a clear-cut view which clubfoot need a conservative management and which need a surgical management, which help us to correct this all the clubfoot with the help of this classification. Sir, similarly, sir have a comprehensive cerebral palsy program and sir now currently practicing in Mumbai. I hand over to Dr. Atul Bhaskar to give us a lecture on relapsed clubfoot. Thank you, sir.
Thank you, Chinmay and Molan, and I'll just share my screen. Okay, so is that clear? Is that?
Yes, sir.
Yes.
So my topic is going to be on the approach to a relapse clubfoot and how we came up with the classification system that kind of helps us to decide more or less what treatment can be offered to some of the children who come very early with relapses. So my experience actually with clubfoot started in 1991 during my training at KM Hospital. At the time, there was really nobody putting plasters, and in 91 nobody had heard of the Ponseti technique. And after that, I did my training in Wadia Hospital also. We never did Ponseti there. It was only in 2000 when I went to Toronto is where we started. I first and saw the treatment of clubfoot by the Ponseti method. And then on my return back, we started this treatment as Molan, as also has been a Ponseti fellow, and we've been doing that. But of course, there are some limitations to that, and I'll just discuss and share my experience. Let's try and advance my slide. I can't change the slide once again.
Yeah.
So the spectrum of clubfoot really is highly variable in our country. We get children as early as, with mothers come with an antenatal scan showing a presence of a deformity. And then this child who came almost like an adult, he was 24 and he was walking backwards and he had this kind of deformity. And that is the back. So his feet are completely turned 180 degrees and he came for treatment. So you can see everything in between. Right from the antenatal scans to the severe deformities. And does early diagnosis make a difference in terms of getting a relapse? There's a strong dictum by Dr. Ponseti that regardless of the treatment in the initial stages, the clubfoot deformity has a strong tendency to relapse. And we don't know why it happens. There may be a biological involvement or there's a morphology in it. But he's shown that there is excessive collagen synthesis and retraction, particularly up to age 4. And hence the rationale of using the splint for almost 3.5 to 4 years. Because there is abundant collagen formation at that stage. As you correct the deformity, the tendon forms. And if they're not maintained in correction, that's the time when they start to relapse. So hence there is some biology to this kind of relapse. Now, why does it occur? Whether it is based on the initial foot deformity, like I discussed earlier, if the severe the clubfoot, the more chance they will relapse, or it's the biology. And really, we don't know the true picture. But as things get more evolved, people have done histopathologist studies of the fibrous tissue, and they found there is excessive fibrosis in some children and not all. So there may be a biology at play which is not under the control of the surgeon, but there may be ways to manipulate this perhaps in the future. So what is the relapse? Now the definition of relapse after Ponseti is classified as, or is told as recurrence of any component of the deformity after initial successful correction and commencement of the FAO. So there are two important points here. One is the child should have a complete correction and should have a well-fitted foot abduction orthosis. You cannot claim a neglected clubfoot, a clubfoot who has had partial treatment, or a foot that has lost to follow-up, coming back as a relapse. So it is basically the foot has to be completely corrected, and if any one component of the deformity occurs or recurs back, that is actually a classical relapse. But typically, you can get two types of relapses. One, before the walking age. So these we call as early relapses. And late relapses generally happen, I would say, not beyond 4 years. So typically, this was the paper published in 2010. But I think late relapses, if a foot is well treated, will usually present after age 4. Now, there are a lot of reasons for the relapse. And one of them is that the initial modification of the technique. Surgeons now use their own technique. Of course, the principles are sound. They still use the principles of Ponseti. But individual preferences, depending on the situation of the surgeon, the patient, sometimes we tend to modify the technique. The biggest challenge which we found was the brace design, and I'll discuss this, which was one of our earlier papers. The bracing protocol, again, is highly variable. Again, it boils down to compliance and the type of brace. And finally, I think the most important aspect which we see in our society is the level of parental education, societal issues, social issues, which really can impact the relapse. And I think this is one of the thing which is not under our control. And hence, programs like the Cure Clubfoot program and the Miracle Feet, where there are social workers visiting the family, counseling them, I think is an important aspect to prevent relapse. The key thing about bracing, which is under our control, if there is no compliance in bracing, the relapse is virtually 70 to 80%. And this was a paper from Mokunde. And if you have a good brace compliance, you will still get a relapse. And this is where I think the biology plays up. There are some children inherently with a tight clubfoot, with tight tissues, which will relapse irrespective of the brace. So we know now that in our practice, after getting a complete correction, it is a maintenance phase that is more important than the treatment phase. If you do a good treatment, you get a nice supple foot. I think then the maintenance phase is the most important. And this is where really a lot of factors come in. So this was one of our papers earlier on in 2006, where we had written about the problems and pitfalls in the Indian society. And here we looked at only the bracing protocol and the brace fitting. And this was highlighted in one of the multi-center study about the effectiveness of the bracing. And at that time, really, we only had 1 or 2 brace in the country. And we were mainly using the Steenbeck brace, and there were several modifications. Now you can see the variety of braces available. And these are pictures of children where they have got a tight fitting brace or a very stiff brace where the leather is very, very hard, and children get these kind of sores. So we've got a whole collection of these cast problems as well as bracing problems. And sometimes this itself, can give the parents a scare, and they sometimes don't want to put the brace because these scars can be very, very painful, these sores, and they take time to heal. Thus, the burden of relapse is going to increase. Of course, it's not going to be as big as TKR, but this is going to be another subspecialty of treating relapsed clubfoot. Unfortunately, there's not much money in it, so we don't get many surgeons treating clubfoot relapse. But I think, as Molan said, you treat the clubfoot well, your practice will increase. Again, the classification of relapse is not clear. The early classification given by Dr. Crawford and his team was minor and major. So if a child had required a tendon transfer or a repeat lengthening, it was a minor relapse. If a child required a full bone release, then it was a major relapse. So these were basically subjective terms. And this was published in 2007. And this was one of the earlier papers I read about relapse of the clubfoot. Following that, there was a paper from Dr. Mokonde, where he looked at the relapse after tibia transfer. And again, he used very subjective terms based on the deformity which occurs, mild, moderate, and severe. So these are very hard to describe, in a study. So we looked at the limitation of the Pirani and the DiMiglio score to grade relapses, and there are too many permutations and combination to rate a particular relapse pattern. Each score is not equally weighted. So there's a ceiling effect. For example, you may have an empty heel and a rigid equinus. In a relapse case, probably may score the same. So hence we realized that we cannot use this Pirani classification to grade relapses. Again, there was no common language for relapses. We understood that all deformities of the CTV don't relapse at the same time. The deformities progress from flexible to rigid, and rigid relapses occur usually in one plane before they progress and occurs in all the plane. And the most important thing is the foot abduction orthosis influences this relapse pattern. And hence, one of my registrars who was working with me at the time, we were doing a clubfoot clinic, and he's the one who actually told me that, sir, we are seeing the children coming back. Some are mild, some are moderate. And that gave us idea of how to classify these children who come with relapsed club feet. So we proposed this classification in 2013, where we started with very mild relapses, which is flexible, and that is decrease in ankle dorsiflexion from 15 to neutral with knee extension. Dynamic forefoot adduction or supination. But both these 1A and B are flexible relapses. Grade 2A is a fixed equinus. So passive correction to neutral and beyond is not possible. Even if you bend the ankle or bend the knee. Fixed adduction of the forefoot and midfoot. So there's a very big lateral curvature. In this pattern, there's a fixed deformity in one plane, usually either equinus or horizontal plane. So this is the grade 2B. So you may have two deformities here, either equinus or adduction. May not have much cavus and may not have much inversion. And grade 3, which we tend to see more common now, there are two or more fixed deformities. So usually the 2A is very common, which we see in practice. And now we are seeing a lot of grade 3s. So again, this paper was cited in one of the multi-center study, and ours was a prospective study. So we looked at 164 feet with a mean age of 48 months. And we looked at the duration of the foot abduction orthosis in terms of relapse pattern. So we didn't look at the Pirani score, we didn't look at the DiMiglio score, because these were children all who had undergone full treatment and had relapsed after completion of the Ponseti method. So they were already 4 years plus. So this was another classification proposed, I think, from Delhi by Alok Sood and his group. They looked at two more points. One is loss of squatting, and they also graded Pirani score 1 as a relapse. So I think there was this kind of classification is very difficult to remember because there are too many permutation combinations. So for them, if piranha score greater than 1 and difficulty in squatting is an early sign of relapse. And we actually mentioned this in our paper that squatting, loss of squatting is an early sign, at least in our country. But there are certain telltale signs which should alert us that these feet are going to relapse or will need very, very intensive bracing. And this is where the biology comes in. So you can see there's a deep transverse crease. Sometimes you can get very atrophic calf. You can have a very rigid deformity, a short great toe, and poor fanning of the toes. So these are important signs, and this also can be what we classify as atypical club feet. And these ones need a different kind of strategy to prevent relapses. The other warning signs, which are the early functional warning signs, which we look for, is a poor everter power on stimulation. So you stroke the sole of the child, the sole, and you find there's no eversion, there's persistent great toe flexion or adduction with walking, poor toe extension on stimulation, or even spontaneous extension is reduced, dynamic supination on weight bearing, and gradual inability to squat unassisted. So these are early signs, and I think one should always look for every child, any walking child who comes to the clinic who's had a Ponseti method. These are important signs to look for, and one must be alert to start treatment based on these signs. So we looked at our own treatment protocol where we found that the child had loss of ankle dorsiflexion from 15 degrees to neutral. That means this is getting into early relapse. And we have a child who's got one side club foot, so you can compare to the opposite side, and you can see there's a fair amount of dorsiflexion on this side, but this side it comes barely to neutral. So these are the ones I would not hesitate to cast again. I would not, tell the child to go away and come back and we see what happens, because this is an important sign not to miss. And the common cause of this relapse is usually initial poor brace compliance. And here I blame the brace design. Sometimes they get poor fitting brace, parents don't want to put the brace, and they usually relapse very early. Sometimes you don't get adequate correction in the last cast, so you made the foot, you didn't achieve that dorsiflexion which is required. So these children, I bring them back. I recast them maybe for 2 to 3 weeks until I can achieve this dorsiflexion, and then reinforce the bracing protocol. So here I would again go back and then start the brace for about 20 hours and then and reduce it. Many of them will come for, so I would say 50% will come back for a resurgery. So 50% success is there with just a conservative treatment. Now, when you do a retinotomy, this is really not a simple procedure. It looks simple and it sounds simple, but you must see the previous scar where it was placed and the previous incision. Sometimes there is massive intra-tissue scarring until the capsule. So the scar may look innocuous from the outside. And sometimes when you do a retinotomy, you may not get that glide. You may not get the dorsiflexion. And we have seen that when we have opened the tendo achilis, there is massive scarring right up to the capsule. So if the tendon is well palpable, I will then redo the tenotomy. But if the tendon is not well palpable, it's very thickened, you can feel the thickening. And if you feel the thickening is more than 1 centimeter from the outside, that means there's a lot of scarring. And we're doing some ultrasound studies on some of these children, like a study to see which one responds to tenotomy. And these ones I would do an open Z lengthening, especially if they're older than 2 years of age. And you must get at least 20 degrees of dorsiflexion after you do a lengthening. So again, don't compromise on the dorsiflexion. So older child more than 2 years, I would prefer to do a Z lengthening, a formal Z lengthening, and again recast them 2 or 3 times, and then give the brace. So don't take this, even the mild relapses, very, very lightly. So this is an example of early loss of dorsiflexion, which is less than 15 degrees. Every child, now this was a child who was able to squat up to age 4 years. And this is what should be at every follow-up. I make them squat, make them do a single leg hop, walk on the heels, and see the dorsiflexion. So this was a 4-year follow-up, and is well maintained. This is a child who has relapsed, and this is one I would take him back for recasting. If he doesn't respond, then an open surgery. The type B relapse pattern again is extremely common, and we tend to see this when we don't give the foot abduction orthosis in more than 70 degrees. And there's also an inherent weakness of the everters, which can cause this kind of pattern of walking. So the heel stays neutral, and as the child stands, he actually inverts or supinates. But this is completely correctable passively. So you can get full passive external rotation up to 45 degrees. And this is typically seen in children around 12 to 16 months of age when they start to walk. And if you look at the heel, you have good dorsiflexion here. So you can see they've got good 15-degree dorsiflexion, but when they walk, they have a dynamic inversion. So I hope this video works. Sorry, it's not working. And again, you look at the foot size, you look at the foot morphology, and you look at the everter, you look at the lateral side, it may be more atrophic, and they'll have poor finding of the toes. So these ones which come with a relapse, a dynamic relapse, initially I would give them a cast. So again, recasting, rebracing as usual. If they don't respond, around age 3.5, 4 years, we do a tip and transfer. And I also add what is called an abductor hallucis tenotomy. So I do an open procedure here, and I release the abductor hallucis tendon, which is it's called a bulky muscle when you open the clubfoot. And this tendon can also cause a dynamic inversion or dynamic adduction of the foot. So I do both of them in the same sitting. And this is typically around 3.5, 4 years when they come with a dynamic relapse. You've tried all your bracing protocol, you've tried casting, and they don't respond. The other challenge is at this age is parents, they're not very keen for casting for long term because the child is going to attend school. And again, he needs anesthesia. At that age, at 2 and 3, it's very difficult to put a child in a cast without anesthesia. So again, that fear is there among the parents. So sometimes if they're not responding to the bracing protocol, I just go ahead and do the surgery. So grade 2 relapse pattern where you get a fixed deformity in a single plane. It could be either sagittal or coronal. So fixed equinus of any degree. That means you're not able to correct the ankle deformity with passive correction. This is because of the tight TA, tight capsule sometimes. And these ones usually will not respond very well to your casting, although we try casting them. And I know that in academic institutes, people prefer to cast 4 or 5 times. It is not possible all the time in the private practice. Parents don't want repeated general anesthesia. And hence sometimes I try 1 or 2 plasters. If I know it's very rigid, we just go ahead and do the surgery. And I'll give you a couple of examples where when you see scars like these, where there is a good centimeter thickening of the scar, and you find a foot coming like this, that this, there's a lot of scarring at the back. This is dynamic. Supination is dynamic. The equinus is rigid. And that's why you realize that once you correct this deformity only from the back, and you cast them again or we brace them, that should be enough. So you don't really need to do any more procedures because the child is small, the adduction is dynamic, and it's only a pure equinus. So here you can see this child in drop, the amount of deformity he's got. This is the opposite side of the child, and here we do a formal posterior release. So we do an ankle release sometimes. So often I will do only a TA and I will dorsiflex and see. Only if I don't get dorsiflexion beyond 15, I would go ahead and do an ankle release. Now again, remember that the more release you do, the more chance of stiffness. So always try first doing just the TA lengthening, try and get the correction on table. You won't get another chance to operate. So if I don't get dorsiflexion beyond 15 degrees, I will do the capsule release and then back to casting again. So casting again remains an important support system for us to maintain the correction. So this is a child who had undergone twice. He had undergone tenotomy. He had relapsed in his equinus. You can see the forefoot is flexible, and here we did an open TA lengthening and a capsulotomy, and here we did it with a hemi Cincinnati. So you got a nice scar and you got good dorsiflexion. So when you have surgeries done before, it's not easy to do a repeat tenotomy the 3rd time because of the scarring. And again, these ones I will not hesitate to open. Actually see the tendon, make sure you get the length in the tendon, and then do the capsule release as well. A grade 2B pattern where there is fixed deformity or fixed adduction deformity. Here the heel is in neutral and ankle dorsiflexion is possible. It may be reduced, but it's possible. So child can still squat, but primary deformity is the in the lateral plane. So there is a shortening of the lateral column, a lengthening of the lateral column, short medial column, and you can see from his walking pattern, he's walking on the outer border of the foot, and this is not uncommon in the older children. So these children are normally around 3 to 4, maybe 4 or 5 years of age. So these are typically more than 4 years of age children who come with this walking pattern. And sometimes we have what is called the chappal test. You see children, this was again pointed to by my registrar. He saw the child coming like this and he said, "Sir, this foot doesn't look normal." And he didn't know what a clubfoot was actually. And this child actually had a valgus foot. He had a planar valgate foot. And then we made some clubfoot children wear slippers and realized how you can see the heel pattern of these children. If there is a varus, you can clearly see because it moves away from the base of the sandal or the slipper. And this is a very commonly seen when there is a coronal plane deformity. So these ones where we find there is a lateral plane deformity, these ones I would go ahead and do a cuboid shortening and a tibia transfer. So these ones are bony deformities. Again, you can cast them. I've tried casting them, 1 or 2 plasters, get the skin stretched, and then I go ahead and do a bony osteotomy. And I'll tell you the reason why we do the osteotomy. Because if you leave the children alone, they will have problems later on. And I've got some long-term follow-ups of children who have been left untreated. They've had cast treatment only and they've come back during adolescence. Of course, when you have a full-blown relapse, like this, a grade 3 relapse, then you may have to do everything. You may have to do a soft tissue release. You may have to do a bony osteotomy. So what we do sometimes, if there is a massive coronal plane deformity, we do a transcutiform osteotomy and get the plane corrected. So this again is important to get the lateral border straight. And the reason I was telling this because this is a child, we've got 7 children with these kind of coronal plane deformity, and they have come with stress fractures of the 5th metatarsal. So they come with a deformity, and then this child again had a fracture. One more child, he came with a fracture of the 5th metatarsal, and he was 14 or 15. So he didn't. He underwent only casting for his coronal plane deformity. They didn't want surgeries, and now he's come back with stress fractures twice on this foot, and he needs now a surgery. And you can see his heel is well placed. He's got a good neutral heel. Okay, he can go up to 15-degree dorsiflexion. It's only a coronal plane deformity. But when you have deformities in 2 planes, equinus as well as coronal deformity, any 2 planes, so we call it as a type 3 relapse. And now we find this is much more common now, more than the type 2, because invariably some of the children will have rigid equinus. And these are the ones, again, you start with casting. You cast them a few times, 2 or 3 times, and then you can go ahead and do the operation. Most of them will need a bony osteotomy with a medial soft tissue release. So I would not go much into the surgical details. But my approach to these full deformities is casting a couple of times, try and get whichever deformity is supple to correct in the cast, and then go ahead and then do what is called an a la carte approach, what is required for the child. Example like this, again, a full-blown deformity with a complete relapse. He's had foot treatment done. He's only 4 years of age. So these ones, I would give a few plasters and then go ahead and do the complete release. So we looked at our own data. We looked at the bracing protocols, and we found that children who had bracing were braced only for less than 8 hours at almost 80% relapse rate. Whereas those who wore the brace for 8 to 12 hours, they only had mild relapses, the grade 1 relapses. So essentially bracing becomes extremely important, and there was no difference between the bilateral and the unilateral clubfoot. So ultimately is the brace compliance and the duration which will influence the relapse pattern. So the less the compliance, chances you will get a grade 3 relapse. So we're looking at some of our long-term data with CTV. So we're looking at X-rays now. We are looking at the gait analysis, some of the children, and we're looking at the kinematic patterns now in our lab to understand what happens to the children in long-term follow-up. So these are children who are typically 10 plus, who undergone the treatment, and we looked at some of the gait analysis. So we find that some of the children will have poor ankle dorsiflexion. They'll have sometimes their knee will go into hyperextension. And so this is our study now. So this child is now 10 years post surgery, and he is now in our lab. And this is a long-term study. So anybody who's interested can contribute to this. And we plan to publish our first paper maybe by next year, where we have data for the clubfoot children. And this is where we look at the ankle dorsiflexion, the knee range of movement, hip, and of course the foot progression. And this is an ongoing project. And we find that many of the children have problems in the transverse plane. So even tibial torsion in late cases is an important part of the deformity. And we find that many of the children will walk with an internal tibial torsion or internal foot rotation. And that also may require treatment in the long run. So this is an ongoing project, and we are now looking at our long-term data. So in summary, I would say the prevention is more important than actually the treatment. The bracing protocol is very important, and at the end of the day, if your brace compliance is good, I think you will not get a relapse. And now with different types of braces available, with the Cure project and Miracle Club Feet, and we have got a lot of social working environment now where parents are seen by their counselors. I think you need a great mother. Ultimately, the great mother who looks after the child. And I thank everyone for the attention. If any questions are there, I would be happy to discuss cases as well as take some questions.
So thanks, Atul, for that lovely talk. And I'm sure that everyone has learned a way of at least classifying and then to treat those relapses. Now, I was with Dr. Ponseti, and he treated one patient. The patient was very religiously following bracing protocol. And at 5 years, the child relapsed. So I asked Dr. Ponseti, why did it happen so? And he said that we actually do not know the exact age till what time we should put the brace on. So even with Dr. Ponseti, there were relapses with rigid splint protocol followed religiously. And then they had switched to this John Mitchell splint. The good thing about that splint was this splint is taking shape of the foot of the child. In India, I've seen at most of the places the child's foot has to adapt to the shape.
Correct.
So, and as you rightly say, I'm putting this Dennis Brown splint is really, really difficult. Every time they have to, if you think that you wear a formal shoe, and if you wear a shoe with a lace, it's so cumbersome to take it out and put it back in.
Correct.
So we consultant also, we would like to have a formal shoe without laces. And now we are expecting moms to take that laces out and put. So Dennis Brown have a lot of patience. The key thing seems to be, as you said, is the biology. There are children, they do well. Even I have patients who are very supple, hyperlex, and they have worn braces for only 2 years and they are fine. So that's a good point. Now, a few comments and questions for you. The toe adduction and a bit of clawing. At times I have seen it is a surrogate to grip the ground, and some of these patients have hyperlex arches. So I have never treated an adducted and clawed toe, and I have always observed them, and it comes straight by itself as they grow. But if you find a unilateral clawing, then it should alarm you. So not all toe adduction and clawing need treatment. Second thing is, all the fellows must have habit of calculating the amount of dorsiflexion child have, because many a times in a fully corrected clubfoot, the amount of dorsiflexion is not comparable to the other side.
Correct.
If you compare with the other side, you will always find less, but you should have either a photograph or a quantifying what is the amount of dorsiflexion and compare every time. I have seen, Atul, the first component to relapse is equinus. What is your experience? What deformity comes first in most of your cases?
I agree with the one which we correct last comes back first. and that is very common. Again, I would mention two things. One is, see, if you look at these children, when you're doing the ponchari casting, see, remember there's also the FHL and the FDL tendons.
Yes.
And these children, when you see them in the prone position, and you abduct the foot to 45 degrees, you abduct the foot, and you'll find that toes will claw. Because we are focusing only on the tendo Achilles. We are focusing only on the tenotomy of the tendo Achilles. But the FHL and the FDL tendon again comes from the back, and they come medially. And typically you find, I've seen children being put in cast where the cast doesn't extend up to the toes. So they keep the cast below the toes. And when you see this child in the clinic, so I've got a child who come for a second opinion with the cast in the cast, and the toes are bent at the edge of the cast. And I tell the parents that, see, sometimes the surgeon who's beginning to, he's learning the Ponseti, he's doing the Ponseti, he's only obsessed with the equinus. And I've seen that relapses occur. So we are doing some of these. We look at the cast pattern as well. Of course, it's not easy every time. One you see personally, I've seen. And when you examine these children in the prone position, you abduct the foot, and suddenly the toes will tense. The toes will become. That means the casting was not done properly. So I would encourage all juniors to cast right up to the toes, and not only see the dorsiflexion as Dr. Molina said, also when put them in prone position, see the clawing. If you're able to easily extend the toes in abduction, that means that's a good sign. So these are important subtle signs where I find, which are important to detect early.
That's right. Another thing is, the Pirani scoring is very good, but Pirani scoring does not mean the rigidity. It scores the severity, but not the rigidity. You may find a 6 Pirani score, which will correct to 1 in 1 or 2 plasters, and sometimes a 4.5 Pirani score will not come down after 5 plasters.
Correct.
So it's good classification to understand, but this cannot be applied to understand the rigidity of the clubfoot. So I have never used it in my practice. Dr. Ponseti used it ever. Fine. The next question to Atul. What, according to you, is the cause of dynamic supination?
So I think,
I'll tell you brief about this. The first explanation is there is abnormal insertion of T-band. Now I've done a lot of transfers and they are inserting on the same place, the normal.
correct.
Secondly, someone told that it's a surrogate of equinus contracture. And when you do when your dorsiflexors, you have equinus contracture, you try to use T-band more to correct, but there are ample of patients with 15-20 degrees of dorsiflexion, still they have dynamic supination. And the third reason, they say their everters are weak, but I have patients who can do active eversion. So what do you think is the cause of T-band hyperactivity?
So I think there are a couple of papers in literature where they have done the EMG. Of course, they are for older children. And they found that it is the everter weakness, which primarily causes that. The other thing which I agree with you, that we don't know the middle side. I also believe the FHL and the FDL. I don't think we are looking at it very closely. I think they also go on the middle side and the plantar side. And many of these children with the dynamic supination also have got, inversion. They have supination, not only pure inversion. I think a lot of factors are at play. I don't think it is a very easy thing to understand.
That's I absolutely agree with you. That is, dynamic supination is probably beyond T-band.
Correct.
Because we have seen persistent of kind of dynamic supination even after T-band transfer.
Absolutely, yeah.
So what do you do if you have done a T-band transfer in a 4 years old and he's still a bit of dynamically supinating? How would you deal with that?
So one thing is there, first of all, always do a complete transfer. Don't do a half transfer. That is one way.
Yeah.
And so you do that transfer. Sometimes what we do is we release the abductor hallucis tendon as well. I feel that also adds to some of the adduction of the foot. You do a T-band transfer and you get a relapse. That means obviously there is, your everter is extremely weak. Or the medial side, there is some tightness of the. So I would actually go back in and release the medial side. I would do FHL lengthening, FDL lengthening, abductor hallucis sternotomy, cast them. since you already done, you already used a tendon, the only thing you can then do is placate the peroneus tendon. So I've done peroneus brevis placation sometime just to tighten it. But at the end of the day, again, you have to brace them. I think bracing is again the key thing. I've also given Botox to peroneus following the transfer to weaken to the T-band, to weaken them. To the transfer, we've done the Botox. So I think I would do a release. I've done releases, I've done the FHL, FDL, and then put them up again on a brace. And you find, I think if you look at it, the brace design or the brace compliance will be poor in these children. So you go back to 70 degrees and recast them. Of course, if they come back again and again, then you have to look at it. The EMG, you may have to look, there'll be subtle neurological weakness. I think all those factors will come in play.
So there is always a question in my mind that is it the deformity which makes this non-compliance to the brace or non-compliance, that. Anyway, so that's right. So yes, Shalin and Chinmay, you can ask the questions.
Yes, sir. There are sort of few questions. One is from Dr. Sheenam that in more severe deformities, correction of substantial stiff equinus place the posterior tibial artery and nerve under stretch in tarsal tunnel. What to do in these cases?
Sorry, what's the question?
In more severe deformity.
Yeah, okay, I can read it. Okay. It's, right. So if the deformity is, see, normally I would take the Cincinnati approach, but if a child already has a scar, then I'll follow the same the pattern of what is there. So you don't correct the equinus completely. So even after Cincinnati, you keep them in slide equinus for the first 2 weeks. And this I learned from Dr. John Wedge, that in a neglected clubfoot, you do a Cincinnati approach, you can always come back and close the wound later on, but don't try and correct the deformity in the first go. If it's very, very rigid, you will stress the nerve. And I've seen children getting horrible paresthesia. So you do the soft tissue release as you'll do a conventional clubfoot release. Make sure you've got everything corrected. Undercast them, undercorrect them for the first 2 weeks till the wound heals. And then you stretch them. And I've found very rarely I get skin breakdown or any of these problems with nerve or vessel. Often you will not find the vessel problem. Vessel is very, very pliable. It's the nerve which can cause issues. And that I think you should be always undercorrect in the first cast and then correct subsequently after 2 weeks.
So there's one more question. Is there role of Dennis Bound's shoes in walking children who have some early signs that may suggest the pending relapse?
Of course, I think there is role of DB shoes. If the compliance has been poor, if it's a rigid deformity, I would not give it. So if there's a rigid component, I would not give it. If it's flexible, you suggest a surgery to a child, parents will not go in the first, in the first instance. They'll tell you, we'll try with bracing, we'll try with physiotherapy, they'll take another opinion. So there's always a role of DB splints in a flexible deformity. There's no harm in trying them as long as they want, till they're convinced it's not getting corrected. Don't offer surgery. Let them ask for the surgery. Let them say, okay, I've tried all these things. It has not got better. What would you recommend? And then I think you're on the winning wicket. You do something early on and they come back with another relapse. Then really you have no questions. So bracing, casting is always conservative, always, safer. You can try it as many times. There are papers from Bangladesh and Nepal where they're given 25 plasters. That is not practical in private practice. Honestly, it is not practical. In my BMC hospital, I have given 10 plasters sometimes, But surgery should be your last option. So try everything else.
So what will be the age for tibialis anterior transfer, sir?
So I would not do it earlier than 4 years, 3.5, 4 years. If you do it very early, I think the relapse, you're not really corrected the flexible part of the deformity. So first you try and maximize your bracing till 4 years. And then the tendon also has a good size. In a smaller child, the tendon is very, very thin and small, and it's sometimes doesn't have the strength. So 3.5, 4 years plus is a good age to do it. And that time the picture is more clear. It's purely a flexible relapse, and you may get success with T-band. So T-band itself is not a benign procedure. It sounds easy, but it's not a panacea for your inversion deformities.
So have you seen any improvement in dynamic supination with therapy only?
Yeah, certainly. I think the flexible part improves considerably. So if you can increase the duration from 12 to 16 hours, I would actually recast these children. When I have a dynamic deformity, I will give them 2 or 3 plasters. So the parents understand the importance of splinting. You do one cast and they think, okay, one cast is nothing. So they have to be, reinforced that this is not a benign thing. Let me give 2 or 3 plasters. If they're not convinced by 2 or 3 plasters, I would say then you go somewhere else, because you take it lightly, they will take it even more lightly. So one must reinforce this child needs 2 or 3 plasters. It is still dynamic. We still have the upper hand. Let's try and get it corrected now before you end up, needing a surgery.
So you
Yeah, so
mentioned.
my experience, with the physiotherapy is stimulating the peroneal and the lateral, everters has not been that great. I was with and I was in with Morquindu in Sri Lanka, and I told him my rate of T-band transfer, and he said that in last 5 years I have done only 2 T-band transfer. I said, why? And he said earlier on, we used to do T-band transfer after 3.5 years, once the lateral cuneiform gets ossified. But then they delayed this age to 4.5, 5 years. So some of these children, they, as their gait got mature, they started controlling the foot and the deformities got corrected by itself.
Correct.
So earlier on in Iowa, they had very high rates of T-band transfer. Now that has gone down. So after that, I have delayed my T-band transfer surgeries. And in the meantime, then I would send patients to therapists. And some of them, they improve partly, and some of them, they don't. And of late, few patients told me, sir, आपको ये surgery करना था, तो 1 साल हमारा therapy क्यों करवाया? इतना पैसा खर्च कर दिया surgery जितना. So I'm not sure whether, because they could do eversion actively. So they didn't have peroneal weakness. And then the therapists tend to do this
taping. They do a lot of taping.
Yeah, they do taping.
I don't know. They also want to experiment, So I really don't.
Yeah, so
therapy. The mother's the best therapist.
What I feel is till the physiotherapist impress the family,
correct,
they find that the feet are corrected. Correct. The moment there is some displeasure, suddenly correct, the foot starts to revert.
That's true.
Anyways, let's go on to the cases. And
one more question, sir.
Please.
Yes, sir. One more question from my side, sir. You say that in 2B and 3, we do a casting and we then go for the surgery. So what will be the goal for our casting, sir? Is just to stretch out the contracted soft tissue, or anything more we see on a casting, sir?
This is for the grade 2B?
Yes, sir. 2B and 3.
So yeah, that's interesting. See, I discussed the paper with Dr. Peter Smith when I was in Chicago. And so he was telling Atul, it is not easy to get only one deformity in one plane. There's always some other thing which is happening. And I sent this paper to Dr. Pirani before it got published. He actually never got back to me. So when I met him in Nagpur, I told him, sir, I'd send you this paper. Of course, he didn't say anything. And then he came out with his own classification, the Pirani-Sinclair classification. I don't know if anyone has read that paper.
No.
That paper was published by a Swedish fellow. It was the Pirani-Sinclair, Mark Sinclair from Middle East, and there was a Swedish fellow. Anyway, that's on the side. But I would always cast them because there may be a flexible component of some deformity which will get corrected. Secondly, it also tells me that the parents are ready. They have got, the compliance is important. So casting has got a lot of advantages. One is, you cast a child, you see how he is, because they're older children, they will break the cast.
Yes, sir.
So I always put a rigid cast, one of the fiber casts.
Yes, sir.
Get 1 or 2 flexible deformities corrected. It may or may not stretch the skin. I've not had wound problems in these grade 2 because you're going to shorten the foot anyway when you do a cuboid osteotomy. But casting will correct some supination, will correct some, will give some stretch. And again, the compliance is important. So I look at the compliance, the parents' acceptability. I think these factors are important in our society. And then I would go ahead with the surgery.
Okay, sir.
So we have 4 quick cases. So let Sheenam start, and then Meet, and then Dr. Godhasiri. And Sheenam, you can share your screen now.
Okay, sir. I'm going to present 2 cases of neglected clubfoot. One is in scantily immature child and other is in mature. This 5-year-old boy, never being treated, presented to us with this deformity. equinus, cavus and varus was present, and there was rigid deformities. There was no associated neuromuscular condition.
So, yeah, Sheenam, thanks. Now, equinus was rigid, of course. There was rigid equinus.
Rigid, yeah, correct.
Yeah. So now this is a child of a vegetable vendor. They went to pediatrician after birth and they said कि थोड़ा बड़ा होने तो उसके बाद treatment करेंगे. And so they came for the first time to Annie and to me at 5 years, and I said, why you did not receive any treatment? And they said that our doctor said that थोड़ा बड़ा होने दो. So now, so they have not received any treatment so far. They're vegetable vendors. Earning, their daily wages, so they cannot spare much time. They do not have time for rehab and coming back and forth for corrective plasters. So how would you deal with this, Atul?
So, looking at the background of the family, this child, I know again, if we just give plasters, 10 plasters, he may not come back.
Yeah.
So certainly, I will first, of course, counsel the parents that this feet can be completely corrected only if they follow the protocol properly. I'll give the child maybe 2 or 3 plasters, to be honest. I'll give 2 or 3 plasters, try and stretch the skin. Other thing, the reason I would give it, to make him stop walking like this for a few months, for a few weeks. Because he's only going to enhance the deformity by walking like this. And make our life difficult. So I'll give a couple of plasters,
Right.
short GA, and then try and get whatever deformity can be corrected with this, with casting. And I don't hesitate even at 5 to go ahead and do a Cincinnati approach, do a complete soft tissue release, add a tib-band transfer if it requires a bony shortening, do everything in one go, giving the background.
Yeah.
And then what I do is 4 weeks, I change the plaster at 2 weeks and 4 weeks. The 4-week plaster change, when I do, I get them measured for the splint, the shoe and the splint at the same time. Cast is kept anywhere between 8 to 12 weeks when we remove the wires. But as soon as the wires are out, the splint should be ready on day 1. Because if you delay them to give the splint, again, he's going to run away. So somebody will give in his background, I'll probably do the casting and then do whatever is remaining. I'll go ahead and do an a la carte approach and get the foot straight, because I know he will disappear again. He may not.
I know. So, the same year, I think I have treated this child before about 10 years or so. The same year, Neeraj published his paper on dorsal wedge resection, and he at Nagpur, he's been dealing with a lot of tribal people. So I found the profile of this child same as those sort of families. So I decided to go for dorsal wedge resection and heel cord lengthening. So Sheenam, please show what we have done and the outcome.
This is 3 months after surgery, and this is 12-year follow-up.
So this is just yesterday. I called his father, and you see he's a 14 years old boy.
Correct.
So I must compliment Neeraj that this technique works for a longer period also. Some of them we lose follow-up of these patients, but this patient was kind to send the 14-year follow-up picture. So I have seen some of them that after doing TA tenotomy or release, their dorsiflexion is 7 to 10 degrees, not full. And they after that, probably there is, as they have the anterior talar body is out of the confine of socket, it has probably enlarged and we cannot. So some of them I explained to do a anterior closing wedge osteotomy of tibia also, but some of them, they improve over a period of time. They stretch out the capsule or what. So this is the 14-year follow-up of that boy. They have not come. Somehow they retained their mobile number, otherwise we cannot catch them.
Right.
Yeah, let's go to the next case. But I agree with your plan that we should do multiple casting and then we can correct the deformity. But I found that this patient will not come back for, Yeah. So let Meet present the second one, and then with Sheenam will go for the third.
Yes, sir.
So dorsal wedge resection for all the fellows. There's a nice paper from Viraj from Nagpur, and we should. I always ask fellows to read that paper along with Atul's paper on relapse. Yeah.
Just a second.
Yeah.
Yeah, so I'll be presenting a case on relapsed clubfoot in a 6-year-old boy. So we had a 6-year-old boy who presented to us with, he was a known case of bilateral clubfoot and was treated with Ponseti casting at birth. He had relapse of the equinus at the age of 2 years. So we managed that with cast and a percutaneous tenotomy. And following this, however, the patient was not compliant with splints and was subsequently lost to follow-up. So now he presented to us at 6 years of age with this picture. As we can see, he currently walks on the lateral border of the foot, and there is there's heel varus and the in-toeing gait.
So Atul, how would you grade this?
So, so his coronal plane deformity is fixed.
Yeah, it's on the left side. It's partly correctable, but not. I cannot bring the foot to the neutral. So there is a bit of lateral column lengthening.
Correct.
Yeah.
So that means he's got like a type 2 relapse where there is mainly a coronal plane deformity. Is he able to squat? What is his ankle range? His dorsiflexion range?
Sir, his
yeah, Meet.
His dorsal. So just coming on to the examination points, he had a rigid deformity. Equinus was rigid.
Okay.
Cavus was partially correctable. Varus was also partially correctable. The forefoot adduction was fixed, and he had a long lateral border, and there was no underlying neuromuscular condition.
So Atul, when we see a relapse, I ask the fellows to chart these things,
Correct.
and based on this, we sort of do the a la carte approach.
Correct.
Yeah.
So here you have 2 rigid deformities. So essentially gives you a type 3 relapse where it's more than one component.
Right.
So, and this child is now age 6 with no neuro problems.
Yeah.
Yeah. Now see again, if you look at the history is interesting. He's had a tenotomy. He has lost to follow-up. Again, he's come back, at age 6 probably because the parents realize he's going to school now. Footwear is difficult.
So this family is from Atul. This family is from UP actually.
Okay.
And they are, a father is doing jobs. So some few years they are here and few years they are back in hometown.
Correct.
So, yeah.
Yeah. So he's got 2 components which are rigid. And again, here, primary casting to whatever you can get straight. But here I would again offer the child surgery. And here we would do a lateral column shortening. And I also do a medial column release. So I do a transcuniform osteotomy because you need a plane where your hinge opens up. So if you do a medial release, so at the same time I do an abductor hallucis tenotomy as well. If he's got no clawing, then I will leave the tendon just open the sheath of the FHL and the FDL to improve the gliding, but not do any lengthening, formal lengthening if there is no clawing at the end of my surgery. So do a medial release as well, a small medial release, do a cuneiform osteotomy where the hinge will open up, do a lateral column shortening, middle of the cuboid, fix it with wires, and then do a tib and transfer at the same time. So you get all deformities corrected. The equinus, if it's rigid, obviously will need also a surgery. So this I do so I take separate incisions. I would not do a Cincinnati for this. So I'll take a small longitudinal incision, release the tendon achilles, see if I get dorsiflexion. If I'm not getting 20-degree dorsiflexion, release the capsule as well from the back. And you can release slightly the middle capsule of the ankle joint as well and the subtalar if there is varus. But be careful with the medial release at this age because you don't want to overcorrect them. And then go ahead on the lateral side. Do the work on the lateral side. Do a cuboid shortening osteotomy. Put the tib and into the third cuneiform. Again, do a complete transfer. Don't do a half transfer here. And then again followed by bracing. So bracing again becomes important for this child. And these children do well because he's idiopathic. And we've got some good long-term follow-up of these children where, they've been doing extremely well up to 10 years.
Yeah. So can you go back to the video? So now we were concerned about the left side, but even right side is dynamically supinating,
right
right?
also is got right. Yeah.
Yeah. So, but the family was like, "Ki sir, ye to left side mein hi hai na, right side to theek hi lag raha hai humko." So I suggested that I will do T-band transfer on the right as well, because there is the mild adduction and dynamic supination, but they didn't want anything to be done on that side. So Meet, show what we have done.
So based on the examination findings and the a la carte approach, he had a rigid equinus. So we went for Z lengthening of the tender Achilles, and since adequate dorsiflexion was not obtained, we went ahead and had to do a posterior ankle and a subtalar capsule release. For cavus, we performed a percutaneous plantar fascia release. For the long lateral border, we performed a cuboid decancellation, and for forefoot adduction, we did tibialis anterior tendon transfer.
Right.
So at the end of this is a 2-year follow-up. The left side was operated upon, and now as is visible, there is no long lateral border. Patient is currently walking with the foot flat.
So did you also cast the right side? So you have an opportunity
No.
to.
So that's what I wanted to show you, Atul. You see this dynamic supination is resolved on the
better.
right
Yeah.
side, you know.
Yeah.
So
So
some of
sometimes you get a chance to put a cast on that side because he's already in a plaster. Don't do any surgery. They will get better. You know, sometimes it's just a pattern of walking.
Yeah.
So I cast the opposite side and tell the parents it will get better with casting only. You know, it's a very mild.
Yeah.
You can work on the muscle. Yeah.
So I don't remember whether I did cast or not, but some of this mild dynamic supination, we should wait for a little longer time.
Correct.
And
they improve. Yeah, that's right.
They improve. But the ones with fixed deformities and long borders, now we can see the still right side has a little longer border.
Correct.
So if there is dynamic supination, it will gradually turn the foot in, and then they might come for the surgery for the right side as well. Yeah. Okay. Fine.
The left side is well corrected, and only now is the right side deformity quite apparent.
But the parents are not concerned with this, you know.
So that's why, you know, I like I said, you have a chance, you counsel them for the casting here in the first time.
Yeah.
So at least they know the child is in plaster anyway, giving anesthesia, you're going to change the cast. And in 2 plasters, this will correct. Actually,
Yeah.
very in mind.
Thank you.
Yeah. So let's Dr. Godhasiri present her case. Godha, you can present. Is she here? Okay. So Dr. Godhasiri is our next fellow. She is from Hyderabad.
Sir, are you able to see the screen, sir?
Yeah, we can.
Yes.
Yes, sir. So this is a case of a neglected clubfoot, which was managed with Joshi's external stabilization system. So a 20 months old female child, she presented with bilateral congenital talipes equinovarus. She was initially managed with serial casts. About 4 casts were applied. And due to certain family issues, the treatment was discontinued. And after that, she later went to another orthopedic surgeon where another serial casts were applied, like about 20 casts were applied, and the correction was not achieved. Then she presented for further management. So this was the condition. The Pirani score on the right side was 6 and on the left was 1.5. So the plan was, I planned to do a Joshi's external stabilization system on the right side and manage the left side with casting. So this is the immediate post-operative showing the fixator in situ, as well as we can see the deformities in this. And the differential distraction was started on day 3. The child is quite comfortable with the frame on. So the medial side was distracted at the rate of 0.25 mm 4 times a day, and the lateral side 0.25 mm twice a day. And after all the cavus adduction and varus were corrected, the dorsiflexion was corrected gradually. And this is post the correction in progress. And all the correction took about 6 weeks. And after that, I kept just in situ for another 8 weeks. And the fixator was removed under short GA. And then a POP cast was given. This was given, I gave a above knee POP for about 2 weeks, followed by a below knee POP cast for 4 weeks, along with a synthetic cast so that the child can walk. And this is the follow-up showing good correction of the deformity. So this was my first, just any input, sir.
Yeah, so there's a nice correction. We see lot of such patients, like 20 casts and 25 casts. See, average number of plasters we require for an idiopathic clubfoot is 4 or at the most 5 now. So certainly the technique, we are not impressed by the numbers of casts anymore. When you require more than 5 plasters, that means that the technique is not correct.
This was actually done by somebody else.
No, I realize that. So I agree. So we have been, and you will see when you come here, that we try to re-employ the Ponseti technique in these patients. And I don't know last week whether you attended this Dr. Kamlesh's session. There we have presented some children with similar deformities at the bit more age of 4 years, and we could correct it with Ponseti plaster. Some of them, they do not burge with plaster, and then we might have to add some soft tissue releases. But this is one of the ways. And first we have to convince ourselves that the patient would be comfortable with the frame, and then we have to convince the family, you know. For me, I always found that once we correct, some of these patients have clawed their toes, even though you put something or you put wires or something. And for correcting that clawing again, because Atul said there is FHL, FDL are tight, and then we have to stretch them. Sometimes we have to tenotomize them or fractionally lengthen them. So my use of fixator has narrowed down to arthropoetics, which have failed Ponseti once or twice. But the rest of them, due to these reasons, I have found ways to deal without. But Atul, what is your take?
So yeah, that was a good result. And my take also is that, see, that child had 20 plasters. So if anybody had suggested one more plaster, they would have gone away. So probably fixator was a good idea because they already had seen maybe the plaster was not put correctly or it slipped. And I agree. Now, if you need more than 7 plasters in idiopathic clubfoot, that means there is some person who is not doing it correctly. Now, fixator, I think, is good to have knowledge of it. If you have good knowledge of it, it works in select cases, especially where there's a lot of scarring, when there is issues with rigidity. I mean, you showed a good case in a primary clubfoot, but I think using it very early, I've seen Joy Patangar represented his data at the EPOS meeting, and he had some good results. So it certainly works in hands if you're well trained. But today, like Molan said, I would, you reserve it mainly for children who have syndromic club feet, probably arthropoedic, or if there is bad scarring. And I know I cannot, the skin may have issues. In those cases, I've used the ring fixator with a colleague of mine, and only thing it needs good compliance. The child has to come every week. That compliance is again important. So I know once you put the fixator, the child will not go away anyway, because you have to manage that. So it's a good way. It's a good armamentarium to have so that you can do it in cases where your soft tissue may cause complications.
Yeah. So Goda, I have kept one case for you. I have one arthropoedic relapse. When you come, we'll do it together. And you have to convince me to use in more. Okay, I am not convinced. Shalin is asking, what is the dorsiflexion endpoint in the JES?
So in this case, I've taken like 10 degrees of more dorsiflexion compared to the other side, excessive dorsiflexion to prevent recurrence later.
And do you, I mean, because these young children, they are very cartilaginous.
Yes, sir.
And sometimes, you know, after distraction, they invariably, they cry at some point.
Yes.
How would you judge that you are causing any cartilage compression, you know, although we distract the joint, but
Yes, sir.
why I'm asking you this question is, we at the Healthcare Foundation, we have good Elizaro surgeons,
Yes, sir.
and they have corrected their patients, Clubfoot patients at pretty young age. And when I see them at 10 years in adolescence, they have flat top talus, they develop early arthritis. So how to judge that whether they are having this issue?
So firstly, this child was operated at the age of 20 months. So what I've seen during my training is if they are operated lesser than 15 months, this cartilaginous problem was seen. After 18 months, in the follow-ups which I've seen during my training, I haven't seen any cartilaginous issue. And regarding the flat top talus, generally after 8 years, we tend to see this flat top talus in neglected cases. But what I was taught is once you put the talus back into the mortise, it takes up the shape of the mortise. So as long as you take it back and you put it in a good position, it will take up the shape of the mortise. So in this case, the flat top talus was not an issue. Yeah. After 11, yes, we need osteotomies to correct the flat top talus. After that, it is not going to take up the shape of the mortise.
Shalin is asking, is she able to squat?
Yes, sir, she is able to squat.
You know, the squatting thing is, Atul, I have seen many normal children from urban area, they cannot squat. I do gym, so I know for squatting, you need the flexibility of your quads, your hams, and even your glutes.
Correct. Yeah.
So, and I've seen patients who have more than 15-degree dorsiflexion, still they are not able to squat. So, I don't know whether squatting is a good thing to judge, but many children, they are not able to squat even though they have this thing, especially when they are not using Indian toilets, you know, they all are in the European Western toilets. So that's what my experience is.
A Clubfoot child is a good surrogate marker. So you know, because you see them in the clinic and they're able to squat at 1 year. So it's just a
now I have not been checking this. Yeah, and I'll start checking it.
It's a surrogate marker because you have seen them in the clinic. It's like measuring the intermalleable distance for that particular child. So for that
squatting,
child, it may be useful. I agree that non-Clubfoot children also at 9 years cannot squat. They've never squat in their life.
I've seen many CP children. The family would say that it's not able to squat. Now I've done TA lengthenings. They have 15-degree dorsal, still they are not. So they need selective control. They need, anyways, fine. So let's go quickly to the last case. And Sheenam, please share your screen.
Okay.
So this is the other extreme, you know, the neuromuscular and an adult who came to us.
This 18-year-old male child presented to us with this deformity. All deformities were rigid, and there was underlying neuromuscular condition. We did.
So this boy, he was from Kashmir, Atul, and he was diagnosed to have HSMN, so hereditary sensory motor neuropathy.
Correct.
And he had been to different camps and to various places in Delhi, but probably no one suggested any treatment, and or they were not keen on surgery. But now he is not able to walk independently. He needs support, and now he's kind of having this pressure areas. Sensations were fine, but the motor imbalance was there. So how would you deal with this patient at this age, 18.5 years?
So 18.5, you got any X-rays of his? Any X-ray?
Yeah, I had X-rays, but you look at the foot, and this is that's how the X-ray
Correct,
would
yeah.
look. The body was a bit subluxed anteriorly,
yeah.
equinus, and all those.
And he's not had any treatment so far.
No treatment, no casting, nothing.
Correct, yeah. So I think again the social strata, I think from where he comes, and there were issues. Now, if he's keen on correction, now many times when they come, sometimes they don't want to get corrected. They just say we're happy with it, and that becomes a challenge.
So this now, what happened? I remember distinctly for this boy, as he has entered into puberty and gained a lot of weight. Now it has become a painful foot.
Correct.
So
Correct.
far he was young and he used to do everything, but now they want to get it corrected.
So these ones usually, I think you see the X-ray, you evaluate the deformity. I think he will probably end up needing a triple arthrodesis with a soft tissue component as well. And since he's got HSMN, there'll be some clawing of the toes, and that usually may get corrected when you shorten the foot. Some of that gets corrected, or you may have to do what is called a Godhasiri procedure or a PAP joint fusion if they're rigid joint deformities. So I think the X-rays become important to know where the pain is. But certainly he's a candidate for an extensive procedure. So one has to combine a triple with the soft tissue surgery based on his correction after the hindfoot. And they will need a cavus release. So they will also need often a Steiner's procedure. He may need a first state dorsiflexion osteotomy to get that straight if it is plantar flexed. And then for the short toes, normally they would need something like a girdle stone, or sometimes I just do a PAP joint fusion so that the toes are straight and they're not pointing down. Otherwise, they will get sore on the tips. If his sensations are normal, then that's a good sign that he won't get skin breakdown. But again, these ones, one must wash the skin. You see them at 3-4 weeks. You may have to repeat the casting. Cast duration maybe for almost 12 to 16 weeks, especially if you're doing a triple arthrodesis for these patients. So they end up with a stiff, plantigrade foot. That means they're able to weight bear better. Their pain goes away. And I've got some gratifying results with these even rigid deformities.
Yeah.
I mean, the other option is if you're a Elizaro expert, you can combine this with you or a view osteotomy and do an Elizaro. But I have not had any experience with that.
So, Godhasiri, what are the challenges of dealing with this kind of patients with frames?
Sir, V osteotomy is definitely a good option, sir. It corrects all the deformities in a plane. But this problem of foot compartment syndrome, we have to be very careful post-operatively for the first 48 hours. The chances of foot compartment syndrome are very high.
No, I'm asking about how do they respond to Elizaro, and what problems you face when you deal with this neuromuscular one?
Neuromuscular, I haven't seen, sir, as such. But for this kind of a deformity without a neuromuscular this thing, which was very badly neglected, yes, I have seen one case of V osteotomy which was done, and the patient did pretty well. Right.
So now this kind of cases are not new for the polio surgeons. In poliomyelitis, these were very common deformities way back. So I took help of one of my senior colleague here who is expert in polio, and we have done this triple fusion on one side and a Lambri-Nudi triple on the other side, partial talectomy. So Sheenam, please show the outcome and what we have done. Yeah, so this patient went back to Srinagar again, and he just sent this. So I asked him to wear AFO for 1 year, but we could make him plantigrade. And his father was running a publishing house, so he called that he has started working, and is he looks like Virat Kohli, you see. So I called him yesterday, and now he's I think 25 or 30 years old or something, I don't know, 26 years old. And he's maintaining this correction, and his father said the difference, he's running his own business now, something in carpets, Kashmiri carpets. So, but I was happy to see that this deformity has not come back. He has been wearing a sports shoe. I asked him to send another video without shoes, and there is mild kind of supination thing. But he is managing himself. One advice I give to this patient is do not put on a lot of weight, because weight is directly associated with foot pains and deformities. So, right. So thank you very much, Sheenam.
Thank you, sir.
So thanks, Atul, for your great talk. And
Thanks,
yeah, so all the fellows, one must learn to first quantify the relapse. What is not there in Atul's classification is whether it is neuromuscular or not, because why it is important? Because in neuromuscular, you need long-term splinting and some tendon transfers, like we have been doing tibialis posterior to dorsum transfer sometimes. But for idiopathic ones, this is a great classification, and we have to follow his protocols. So thanks, Atul, for that.
All right.
Nice talk.
Thank you. Have a good day.
Thank you, sir.
Yeah, have a
Thank
good
you,
day.
sir.
Bye.
Sheenam, you can stop recording now, I think. So have a good day, everyone, and we'll meet next week with congenital vertical talus. Dr. Ashish Ranade will talk about it, okay? If
Yes,
anyone wants to present a case, then you're most welcome. When there are two moderators, I expect one moderator to introduce the faculty and the other to ask the questions. Okay?
sure.
So let's keep that in mind. How is life, Chinmay, otherwise? Great?
सर सही चलो सही
कैसा चल रहा है काम?
सही चलो सर अभी बस एक फरवरी मार्च में ओपनिंग हो जाएगा
अच्छा, तो अभी कहाँ करता है ऑपरेट?
सर अभी तो प्राइवेट में जाता हूँ सर सीनियर के यहाँ पे कुछ केसेस रहा तो वहीं पे करता हूँ बोटॉक्स किया अभी सीपी में
तेरा अच्छा है यार, मैं तो पहले 3-4 में कुछ भी नहीं किया था।
अरे नहीं सर आपने सिखाया इसलिए समझ गया कि क्या करना है इसलिए और कुछ नहीं
So my first 6 months I have done only 2 or 3 cases. Anyway, so you are doing better than me.
नहीं सर
Okay. Shalin केम छो भाई?
शालीन चला गया सर शायद
Shalin गया, हाँ. Okay. Hi Vivek. So Vivek. Okay. So Vivek is from Coimbatore. So anyways, see you next week, guys.
Sure, sir. Thank you, sir.
Bye-bye. Take care.
Thank you, sir.